What's up, everybody, and welcome to this week's edition of Da Vinci Cases. Alright, so the way this works is we've got a clinical case followed by a board-style question. So we're going to go through the question stem, point out the relevant clinical findings, take a look at the question and the answer choices, and then kind of divert for a minute and go through the relevant concepts to answering the question. Then we'll come back and apply those concepts that we went over to answering the question. Alright, so we've got a 26-year-old woman who's presenting to her physician's office for numbness and tingling in her shoulders, arms, and hands. So we've got a younger woman here, and she's presenting with neurological type symptoms. Could also be an MSK problem. Could be, some like a rotator cuff problem or some other type of shoulder pathology. Could be problem in her spine, like a disc herniation, stenosis. So let's keep reading here to see what the rest of the story tells us. These symptoms have been occurring for 2 weeks with no apparent cause. So this is not really a trauma. It's not something that's happened right away, but it's also not something that's a chronic problem. It's only been happening for about 2 weeks. And it really has come out of nowhere, as she says. So on the neuro exam, she had normal tone, 5 out of 5 strength, and 2+ reflexes in both upper extremities. So this is telling us that she has normal strength. It's not impacting her motor inputs to her muscles. She doesn't have any upper motor neuron signs like increased tone or hyperreflexia or anything like that. So it appears that her motor function is intact in the upper extremities. However, she has decreased sensation to pain and temperature over the C5 and C6 dermatomes in both upper extremities. Now, we'll show you the C5 and C6 dermatomes in a minute here, but they generally cover the shoulders and the lateral aspects of the upper extremities. So this is corresponding to what she's talking about, where she's got some numbness and tingling in her shoulders, arms, and hands, and it's bilateral here. So again, this is pointing towards a neurological problem. It could be something with the spine itself or the spinal cord, especially given the specificity here that it's in these specific dermatomes and that it's specifically impacting sensation to pain and temperature. That tends to point towards more of a spinal cord problem. She had normal sensation to position and vibration in both upper extremities. Again, the specific loss of types of sensation, meaning pain and temperature, and then she has normal position and vibration. This tends to point more towards a spinal cord because, as we'll go over in a few slides, the cross-sectional and anatomy of the spinal cord, different regions of the spinal cord carry tracts that are carrying inputs that carry different types of sensation. Pain and temperature is localized to one region, and then position and vibration are localized to another. And then motor as well is also localized to another region of the spinal cord. The patient had normal gait and denied experiencing urinary incontinence. So she's got normal balance, she's able to walk properly, and then denied experiencing any urinary incontinence. That just indicates that the inputs to her bladder are not impacted by this, which they can be sometimes in a spinal cord lesion. She has a past medical history of Chiari syndrome type 1 and then migraines. Chiari is going to come into play here. You'll see why in a few slides. And then she is not currently on any medications. This is obviously a neurological problem, so we want to look at what is the neuro exam telling us. So the major neurological findings, and remember with neuro, oftentimes the normal findings are just as important often as the abnormal findings. So she's got normal muscle tone and muscle strength bilaterally, so like we said, her motor inputs on both sides are normal. She does, however, have lost a sensation of pain and temperature in the C5 and C6 dermatomes bilaterally, and then she has intact position and vibration sensation bilaterally. So this is a dermatome map. This is obviously anterior, this is posterior, this is lateral. So let's look at the C5. So C5, as you can see, it goes right over the shoulder like this, and then the middle or lateral aspect of the upper extremity, and then C6 you can see is the lateral aspect of the hand, the lateral aspect of the arm and shoulder as well. And then if we look on the posterior aspect, C5 stretches here across, again, the posterior aspect of the shoulder, even up into the neck a little bit. And then if you look at C6, this is the lateral aspect too of the upper extremity and the hand here. The fact that it's bilateral, the fact that it's covering these specific dermatomes, we can probably eliminate some of these answer choices right here. So the first one, impingement of the right C5 spinal nerve. This is likely going to be due to a disc herniation that's bulging out to the right side to impact this C5 spinal nerve. And because of that, it's going to result in unilateral pain, numbness, and weakness. So this does not appear to be the cause in our patient because it's unilateral and she has bilateral numbness and tingling and loss of sensation and pain and temperature on both sides. Not only that, her motor strength and motor tone are normal. Typically with spinal disc herniations, you're going to see motor weakness as well. You're also going to see a lot of significant pain, especially radiculopathy, which is that pain and radiating from the neck all the way down the arm into the hand. And again, she's not complaining of that either. Compression of the brachial plexus between the right clavicle and the first rib. So this is actually what's called thoracic outlet syndrome. This is particularly rare, but you do see it show up a lot on exams because it's a good test of anatomy and neuroanatomy. And again, this is only going to be affecting one side. So similar to the disc herniation, you're going to see unilateral pain, numbness, and weakness. The other thing with thoracic outlet syndrome is it's not always just a neurological pathology. Sometimes it can be compressing the subclavian artery or the veins draining the upper extremity. And so you can see cardiovascular issues as well. And again, what really eliminates this answer choice is the fact that it's unilateral. It's on one side. And then also is you see the weakness here, which this patient's just not complaining of and doesn't exhibit that on exam. So the remainder of all these answer choices involve the spinal cord. So let's talk about the spinal cord cross-sectional anatomy here just to review. So we've got motor over here in red. And this is going to be mainly the corticospinal tracts, as you can see here and here. And so that's going to be affecting those regions there. In this patient, this is normal. And then you have the dorsal columns, which are this region right here. It's a dorsal column. And so this is going to be position and vibration. And remember, that's intact as well in this patient. Then you have the spinal thalamic tract, which is, as it indicates here, the anterolateral system is the anterolateral portion of the spinal cord. And these fibers are carrying pain and temperature inputs, which this patient is missing on both sides. So something I want to point out, though, is one of the answer choices talks about impingement of the ventral commissure. So you can see here's the central canal here. And this is where CSF is traveling. Now, just anterior to that, you have this region here called the ventral commissure. And you can see it incorporates gray matter just anterior to the central canal, and then it also has white matter as well. So this is the ventral commissure. And what's particularly important here is the white matter in this case, because for the spinal thalamic tract, the fibers carrying pain and temperature, they're going to, remember, enter from the dorsal root and enter the dorsal aspect of the spinal cord. So let's say this is the left side, this is the right side. So fibers coming from the left side are going to come in here. They're going to travel through the dorsal root. They're actually going to ascend a little bit in the spinal cord on the ipsilateral side, and then they'll cross over through the ventral commissure and then come over here and ascend up the spinal cord in the contralateral spinal thalamic tract. So fibers from the left side are going to come in here through the left dorsal root. They're going to ascend a little bit, and then they're going to cross over through the ventral commissure and then ascend in the right-sided spinal thalamic tract. Same thing here on the right side. So you're going to have inputs coming in from the right side. They'll come through the right dorsal root. They'll ascend a little bit, a couple levels, and then they'll cross over through the ventral commissure, and then they will ascend in the left-sided spinal thalamic tract. So a lesion in the ventral commissure is going to disrupt this crossing over of the spinal thalamic fibers. So coming back to the answer choices here, based on that spinal cord anatomy, we can eliminate a few more choices here. So demyelination of the dorsal columns of the spinal cord. So the dorsal columns, remember, are position and vibration. And so a pathology particularly affecting the dorsal columns would be trauma directly impacting that region, a tumor impinging specifically on the dorsal columns. B12 deficiency can cause demyelination specifically of the dorsal columns. Multiple sclerosis can potentially affect the dorsal columns. And then tabies dorsalis, this is due to tertiary syphilis, and this also can lead to demyelination in the dorsal columns as well. Again, what these patients are going to have is loss of position and vibration sense bilaterally. And again, she has normal sensation to position and vibration in both upper extremities. So again, this just based on that presentation alone doesn't seem to be the answer choice. The other thing is that the history doesn't fit. She doesn't have B12 deficiency. She doesn't have any signs of trauma or a tumor or anything like that. So moving on to this answer choice, impingement of the ventral commissure. So again, this is where those spinal thalamic tracts are crossing over. This is typically caused by syringomyelia. And this is a lesion where, so you have the spinal cord like this, you have that central canal, and then you have that region here where you have the ventral commissure where those fibers are crossing over like that. And then in the central canal here, you can develop a cyst that then impinges on the ventral commissure, which is just anterior to it. And so you have compression of the spinal thalamic tracts crossing over, and you're going to have loss of pain and temperature sensation as a result of that. And since you're impacting where they cross over, you're going to impact both sides, which is exactly what she has. She has decreased sensation to pain and temperature in both upper extremities. So this is looking like our likely answer choice, but just for completeness sake, we'll talk about the last one here. So ischemia of the anterior 2/3 of the spinal cord. So this is an anterior spinal artery infarction. If you recall the breakdown of the spinal cord, so you have the dorsal columns back here, and then you have the anterior 2/3 is all supplied by the anterior spinal artery. So this includes the corticospinal tracts, the spinal thalamic tracts, and so these patients are going to have both loss of pain and temperature, but also motor weakness as well, loss of pain and temperature, but they're going to have intact position and vibration sense, because this is the dorsal columns are supplied by, or the posterior 1/3 is supplied by the posterior spinal artery. And again, the history here just doesn't fit. Anterior spinal artery, because that artery branches off of arteries coming right off the aorta, it's usually aortic dissection or aortic aneurysm, or surgery on the aorta is often the cause of infarction of the anterior spinal artery. And so the history just does not fit here. So impingement of the ventral commissure of the spinal cord fits with the history. It fits with the presentation exactly. The other thing is that Chiari syndrome type 1, remember I said this would come into play, these patients are at risk for developing syringomyelia, and so that's important. That's an important association to remember. Remember, this is where you often will have impingement of the spinal cord at the craniocervical junction because they have a congenital malformation of the skull at that point, and often that compression of the spinal cord can increase the CSF pressure. And remember, these cysts that develop in the central canal, if you have a cyst that's developing here and enlarging, that's due to increased CSF pressure. Now, this is a smaller lesion. If it were a larger lesion, it could impact the dorsal columns back here. It could definitely impact the corticospinal tracts out here as well. So this would be a smaller lesion because you're only seeing it impact this ventral commissure where these fibers are crossing over here. And one last thing we'll point out is that this is actually what's called the CAPE distribution. And it's because by affecting these C5, C6 dermatomes, or these outer portions of the arms, as you can see here, C5, C6, you're impacting only the outer portion here, the lateral portion. And then you can see where it would extend across the posterior aspect, kind of like a cape, and then it would extend out on the other side, and again, it's going to cover the lateral aspect. So that's why it's called, quote unquote, the CAPE distribution. So if you see that term, that's what it's referring to, is impacting that ventral commissure where the spinal thalamic fibers are crossing over. And you see this loss of pain and temperature on these lateral aspects of the upper extremities bilaterally. All right, that's all I have for you this week. Make sure you check back every Wednesday for new Da Vinci cases. In the meantime, subscribe to our channel for more videos, and then be sure to download the PDF notes for this video on our website at dviacademy.com. Also on our site, you can find our book and video packages for anatomy and biochemistry. And if you want to listen to Da Vinci cases on the go, the audio is available on Spotify. You can also follow us on Instagram for weekly posts and video. And then lastly, if you have any questions about the content of this video or about Da Vinci Academy, put them in the comments and our team will be sure to answer them. Alright, thanks for watching. We'll catch you next time.